Yeah. Okay. So this is on the DEA training requirements for buprenorphine prescribing. And then because that is, I'll be honest with you, it's very brief. There's not a whole lot of content there. I did a little addendum with just an update with some more recent studies on dosing of buprenorphine, particularly in the era of fentanyl, and how that has changed the game a little bit. I have no disclosures. Here are the objectives. It's to really just to understand the requirements because they have changed. And then also to just be aware of some resources. Some of these are free, some of these are paid resources, but they're always for anyone who still needs the training to access the training. So here is some guidance that the DEA sent out back in January. And the actual act that implemented this was signed by President Biden back in December. And then it was in this huge bill where it was kind of packaged in with a ton of other things. And so kind of got lost in the shuffle, I think, until the DEA sent out this guidance in January. And so it removed the requirement for an X waiver. So you'll see that first bullet point there, no data waiver registration. Only requires a standard DEA. In the past, what we would do is we would put our X DEA number, which basically just identifies that you do have the data waiver. And so those don't have to go on the prescriptions anymore. It removed the patient caps in terms of the limit of how many patients any individual provider can prescribe buprenorphine for. And notably, you'll see that last point there, the act does not impact existing state laws that may be applicable. And so obviously, every state is very different in terms of legislation and the barriers that they put to care. And so it did not change any of those. And so initially, this was kind of viewed as a pretty big thing, but then the last little bit of the guidance, just a little footnote they put, that the act also introduced new training requirements. And the DEA essentially just said, hold on, we'll be right back. We'll let you know what's going on later. Because it said that they are actively working to provide further guidance. Oh, my bad. You see my page break there. To provide further guidance, and they will follow up with additional information on these requirements shortly. So basically, what it felt like was happening was we were removing the training requirements. We were removing the need for additional registration, but then we replaced it with what felt like the same requirements, which was a little bit confusing. And it is kind of like that, actually. But there are some key differences. And so this was actually a pretty big move. So functionally, the thing that changed, the removal of the data waiver was the big thing. And so prior to this legislation being enacted, there were roughly about 130,000 physicians across the country who had an X waiver. Less than a quarter of those were actively prescribing buprenorphine, but at least they had the ability to. So we went from 130,000 to now everyone with a DEA license, once they attest to this training, can prescribe. And so that puts us at somewhere like 1.8 million. And so there are a lot more people now who have the ability to prescribe buprenorphine. If those percentages were to stay the same, obviously this is a tenfold increase in the number of people who are going to be writing buprenorphine. Obviously, it's probably those percentages are not going to carry over, right? So the people who are more likely to write buprenorphine in the first place probably already had their X waiver. And so for people who actually intended to write buprenorphine, the X waiver was not as big of a barrier, but it does a lot in terms of how we view buprenorphine, and how some of the potential dangers and issues that people see. It really kind of reduces those barriers. And so if we think about all the medicines that we are able to write on a day-to-day basis and how many very dangerous medicines we write all the time without any additional training, the 8-hour training requirement specifically to write buprenorphine made it feel as though, well, this must be a very dangerous medication. If I need 8 extra hours of training to do it, anybody with a license can write somebody 90 MMEs a day of oxycodone and they don't think twice. But when we started talking about, well, you need this additional 8 hours of training to prescribe buprenorphine, it makes it feel like it's a much more dangerous medication than it actually is. And so the removal of the X waiver was a really big step, and the removal of patient caps as well. Some things that did not change, obviously, like I mentioned earlier, it does not impact existing state laws. So there are already some states who have updated some of their laws and regulations in response to this. But by and large, the laws that were in place before are in place now on a state-to-state level. And there is still an 8-hour training requirement. However, it does not necessarily have to be buprenorphine specific. And so this is what the big change was. Even though there is still a training requirement, prior to this legislation, the training was buprenorphine specific. Now, it was broader than that. And so when we think about the half and half course that most of us did, where it's the 4 hours in person, the 4 hours online, a lot of that, they talk about methadone as well. That training goes over naltrexone. It's not only about buprenorphine, but buprenorphine was a large part of what that training was. And so now it's much broader requirement. And this quote is taken directly from the DEA website. So the training has to be on opioid or other substance use disorders, as well as the safe pharmacological management of dental pain. And so dentists were in that mix as well. And there are a lot of different things that will meet these training requirements, including, but not limited to, some of the training that learners are getting throughout, whether it's their residency for our NPs and PAs when they're getting their degrees. That will count, assuming the curriculum incorporates it. And so there is a note that most professional school curriculums now do have 8 hours or more of this training, but not all of them do. And so this is something that, as more and more schools incorporate this into their curricula, more people are going to be able to attest that they have had that training without having to do an additional course. So the new process is different. It does seem to be a little bit easier. I cannot necessarily verify that because I'm not due for a renewal here for a couple of years, but the idea is the training has to be done prior to applying for or renewing the DEA registration. And so during the renewal process, there is an attestation where you basically just say, yes, I've had 8 or more hours of training on this. And so the old format with PCSS and SAMHSA and the way that went was you would do the training, you had to get your certificate for your training, then you had to get your online certificate, then you had to send both of those into PCSS and they would approve you. And that's streamlined now. Now, basically, it's on the honor system. I mean, if you like playing with fire, you can not do the training and attest that you did. But this is the DEA we're talking about, so do that at your own risk. I would suggest getting the training, both for being able to take care of your patients better, and also just to be able to sleep at night, knowing the DEA is probably not going to kick in your door. There are some exempt parties here. Again, anyone who had the X waiver prior, that counts, and so you don't need any new training. Anyone who is board certified in addiction medicine or addiction psychiatry is exempt. And then this last bullet point is what I was talking about a minute ago. Anyone who's graduated in good standing within the past 5 years from any of these professional schools, whose graduation requirements include a minimum of 8 hours of opioid and other substance use disorder curriculum. And so that is the process now. It's a little bit different, more streamlined. It should end up being a net positive move. This is just me talking. I don't actually have data to support this, but I think the idea behind it is we're going to see more primary care physicians prescribing buprenorphine. We're going to see this move into a primary care setting more and more, which is something that is greatly needed. And so the expansion of access is going to be, I think, down the road, a very good thing. And I think that's the idea behind this legislation and the removal of the X waiver. So we do have some resources for training. PCSS is the provider's clinical support system, and they're the ones who have historically done the 8-hour half and half training and had done the certificate of training. They still have a lot of good online training. If you go there, all of these links should be specific to their training. The AAFP has a lot of good resources. They've got one in particular that is worth, I believe, 13 hours, 17 hours, something like that of CME. So it's above and beyond the 8. And it is free for AAFP members. If you are not an AAFP member, it is paid. And so if you're not an AAFP member, a lot of those PCSS courses, they're done in 1-hour increments. So it's not as it used to be. You do 8 hours kind of all at once. On the PCSS website, a lot of those are broken up into 1-hour increments. And so you can do different, a variety of different CME activities on that website. ASAM, American Society for Addiction Medicine, has a very good resource. The ASAM website is a little clunky, not overly user-friendly, but if you are an ASAM member, a lot of those will be free. And then SAMHSA has some training resources as well. In addition, some of our very own from here at ETSU will be doing a training here in a couple of days over at Stanton Gerber, which is on the VA ETSU med school campus from 10 to 3. And that should be a good training. We've done that at least once a year. I think there have been a couple of years we've done it once or twice a year. That's done locally. We will do that for some of the residents and faculty sometimes, but this one as well. Oh, no, Dr. Troxler. It's postponed. Never mind. That's my bad.
Okay.
Yeah, well, I saw that it was taken off of my schedule on my Outlook calendar, and I thought that was just because I'm on annual leave this Friday, so I wasn't going to be there anyway. But apparently it got postponed to the spring. So pretend like that right half of the slide is there, but please still do pay attention to the left half of the slide. There are some good resources there. So moving forward, really it's about, taking care of patients. I do think this is going to be a good thing moving forward. I would imagine most of us who have prescribing capabilities that are on this had our X waivers already. but perhaps not. And so for some of us, the training may be helpful. And that's all about the new requirements. Are there any questions on that before we I kind of go into my brief addendum?
As far as the training that got postponed, just to kind of flesh that out a little bit, it is confusing, I think, for a lot of people on what the requirements are and what they need to do, but your DEA does hang in the balance if you don't get that done. So be on the lookout for next spring, especially if you have a DEA, whether you need to have it renewed soon or just ever, and you haven't got those hours, it's a really easy way to get it. And we're also hoping to include, I think, the interns from the ETSU programs so that they can get that done. And it gives us enough time to get on their schedule and making a required training component for them. So definitely when they finish and are getting their independent DEA, they will have that that ability to attest that they really did get minimum of 8 hours of training, because we'll be providing that for them and anybody in the community who may want it as well. So just CME sends out a number of emails about really good things that they are offering, and that will be in there for the spring. So thanks.
Okay, so now we've got a few studies here. There were more. These were a few of the larger ones that I found, specifically dealing with buprenorphine dosing with the prevalence of fentanyl. So this is one that was a JAMA Network open study from a couple years ago, and it was on high-dose buprenorphine induction in the ED. There were 391 unique patients, 579 encounters, and so obviously you can do that math there. Most of these people ended up coming back again. And that's actually, I don't have this on the slide. That's how it tended to be. It was most people came back, not there were a handful of people who came back, you know, dozens of times. But that was how it tended to be. And so what they did was they did provider training beforehand, and they stratified people into high dose or low dose buprenorphine induction based really on their clinical severity, comorbid conditions, and clinical withdrawal. And so over these encounters, high dose, which they described as being more than 12 milligrams, because historically 12 milligrams, if you look at the if you look at the SAMHSA quick start guide to buprenorphine, you look at a lot of the PCSS training, actually, when we're doing at-home inductions, a lot of those will say take the buprenorphine in either 2 or 4 milligram increments up to 12 milligrams on day one. And so that was kind of the reasoning for high dose being classified as more than 12 milligrams. And 366 of those encounters got the high dose induction, including 138 of them got doses greater than or equal to 28 milligrams. And so when they looked at their clinical pathway, you know, mild withdrawal typically got the lower dose, unless there was precipitated withdrawal, which sort of kicked them over to the high dose side of the algorithm. And then they were giving doses, typically 8 milligrams was the first dose. And then beyond that, they could either do it in 8 milligram increments or do it all at once. And so a fair amount of these patients actually would get 8 milligrams for their first dose, and then their second dose would actually be, you know, either 16 or 24 milligrams all at once. They had 0 cases of respiratory depression. Nobody was intubated. No one was over-sedated at these doses. They did have 5 cases of precipitated withdrawal. 4 of those were at the initial 8 milligram dose, and all 4 of the 8 milligram doses, the precipitated withdrawal was actually relieved by giving additional buprenorphine. And so this is sort of the anti microdosing is the idea that, right, if we're looking for receptor coverage, the way to get receptor coverage is to cover the receptors, right? So higher doses, we're going to get more penetration of the receptors. But really what this one does well, and they look at different outcomes in each of these studies, but this one, they were primarily looking for precipitated withdrawal and respiratory depression. So this was really a little bit more of a safety study in terms of how it was set up. And the safety was good, as I think most of us would expect. This was one similar. It wasn't talking so much about, again, outcomes were different. So they weren't looking at safety here. They were looking at follow-up primarily. And so this was specifically patients using fentanyl. So there are some emergency bridge programs in California. It was a retrospective study. It was so several hundred patients, and then 59 of them were doses greater than 16 milligrams. And now this is one time, right? So we're talking about first dose. This is what you get. They split these into fentanyl use versus no fentanyl use at presentation. That was lab confirmed, not only self-reported. They did have a rate 1.6% of precipitated withdrawal, which is a little bit lower than average. Look at something like 2 to 3% is a more average statistic. And then there weren't any statistically significant differences in follow-up rates for the fentanyl versus no fentanyl groups. And so at first glance, that doesn't look like it's a huge deal, but it actually, right, no significant difference in those groups is actually a pretty significant finding, because when they were initiated on high-dose buprenorphine, we think of people who are using fentanyl as being more unstable. Now that may or may not be an accurate reflection of the reality, but that is how we tend to view it. And so the fact that there was no difference in follow-up actually is a relatively significant finding. And then I believe this is my last study. This is one, I got a typo, and time to discontinuation. So this is a new study. It just was published on the JAMA Network Open last month. And it was actually a large study. It was a cohort study for patients over a period of about 4 years. But you see there just shy of 6,500 patients. And their primary measures were treatment retention. And we use treatment retention in this field a lot as sort of a proxy for, are people doing well or are they not? Because by and large, most of the data that we have shows that when people are not engaging in treatment and they have substance use disorders, they tend to not do well. We see, obviously, overdose rates are a big thing that we are concerned with, but there are other things that are other outcomes that have been studied in terms of things like criminality, how likely they are to be employed, and any number of other findings that we sort of use treatment retention as a proxy for all of those things. And so this looked at, basically it was very binary. They looked at who got 16 milligrams, who got 24 milligrams. Now you see here, we're looking at roughly 3,900 patients were on one of those two doses. We'll call it 4,000, right? So you got about 2,500 patients who are on a different dose. They didn't look at those. It was just binary, 16 milligrams or 24. And what they found was that at 180 days, patients who got the 16 milligram dose had a higher risk of treatment discontinuation. So the adjusted hazard ratio there is 1.2. It's a relatively small difference. right? But not statistically insignificant there. And so this was just really well, with it being a cohort study, right? Looking back and saying, hey, did these people have different outcomes? And what this study found was that yes, they did. So people who were prescribed higher doses of buprenorphine at the onset had better treatment retention. They did not make any. They didn't split them into, you know, what were their doses like at 1 month and 3 months, and were we tapering, were we having to increase? It was only about what dose did they get on day one. So those are a few studies just that are newer. There was the one from 2021. Both of the other ones were from this year, about higher dose buprenorphine and what some of those outcomes are and the safety profile.
Wonderful. Thank you, Caleb. That was some really good information. I had forgotten actually that the cap on patients had been removed. I forgot about that. It's a good thing to be reminded of. And yeah, I think we're in a whole new era that we've got to get some catching up done on as far as buprenorphine, and it kind of dovetails nicely actually. Like, it's not that big, bad, scary of a medicine. Coumadin is actually a scarier drug, warfarin. You bleed somebody to death, it's rat poison after all. And that just gets prescribed all over the place. Let people do whatever they want to with it. But also that in some of the earlier studies of efficacy of buprenorphine, and looking at negative urines for opioids, that outcome measure, and the kind of the little caveat at the end, like maybe we were stingy with our dosing of buprenorphine. Maybe that had something to do with why people didn't do as well as we thought they were going to do, because I think they maxed out at 16 in those studies. And most people were under 16, like a lot of 2 milligram doses in some of those studies, and that's just kind of sad. To hold somebody at 2 milligrams. So thank you for bringing that forward and talking about that with us. Does anybody have any comment or questions about what Caleb's talked about with us today?
I have a comment and question. I think one of the biggest obstacle of the prescriber to be able to prescribe the buprenorphine is the regulation that comes from the state. That monthly schedule, it's pretty much hard for the primary care to really see the patient every month in order to prescribe. Did you come up with any things that in the future maybe they change those obstacles or reduce the, at least requirement for the prescribing in a state?
Yeah, so there was actually this was a study that I came across prior and looking at something else, and I'll put it in the comments, but it is a study that came out earlier this year on looking at Medicaid PA requirements, which is, again, it's not the only barrier, right, from a regulatory standpoint, but it's a pretty big one. And they looked at coverage requirements at all 50 states, and they took it was more so about what they did with their PA requirements and how they evolved over time. And so they break it down into different basically different barriers. So some of them are about requiring cognitive behavioral therapy alongside the medical visits. That was listed as a barrier. Some of them were about the frequency of drug testing. And so I will download that and put it in the comments.
Yeah, and another thing that you mentioned about the pain management of the dental pain, they haven't changed the restriction that we have for the oral medication to be not being used for the pain management. Is that correct? Yeah. Yeah, I thought that the oral one is only used for the substance use disorder, not for the pain management. But they did want to, just emphasize on dental pain can be managed with non-controlled substance as well.
Yeah. And actually thinking of posting resources and articles, it reminded me I need to get people introduced, because one of the people that needs to introduce themselves actually posted an article in there to share with us. And we've got a question down there, so we'll get to that. And the person who posted the question also needs to introduce. So let me get to the introductions we need to do. Elliot, can you unmute and introduce, please?
Hi, yes. I'm not in a place where I could jump on video. I apologize, but I'm Elliot Pinsley. I'm the CEO of the Behavioral Health Foundation in Nashville. We're a nonprofit policy research and strategic advocacy center, and do a lot of work in anything mental health and addiction related, and have done some significant research and involved in quite a bit of activity in terms of legislation and otherwise on this particular subject. So I appreciate you all talking about this and educating more people. We need it.
Great. Thank you for joining us, Elliot. And Elliot did put an article in the chat to make certain that you guys grab that and take a look at it as well. Samia, if you can unmute and introduce Dr. Jahan.
Hello, so I'm Samia. I'm an addiction medicine fellow, so I'll be here for a year, and I love to join ECHO every week. I think I missed one ECHO when I had COVID.
That is quite all right. It's a good reason to miss. Thank you for being here today, Samia. We appreciate it. Kayla Johnson, if you could unmute and introduce. And you had a question as well, Kayla. Oh, about other CEU opportunities. Are you in a place where you can, I know you're getting ready to leave. Can you introduce? She may not be. All right. Well, her contact info is in the bottom, so I will reach out with her with the things that she's requested. And then we've got, unless they went away, someone simply with the letter K. Letter K could unmute and introduce, please. It is a mystery. Maybe they don't. Right, no camera or microphone. If you don't mind just typing an introduction into the chat then, because you do have access to that, I would greatly appreciate it. Okay, and Kayla is trying. All right, wonderful. If you can just put it into the chat, that would be great. And that way we have a little bit more of an idea of who the wonderful K and KDJ are who have joined us. I would appreciate it. Any other comments or questions for Caleb, or even patient cases related to access, like maybe how the change in the X waiver requirement being gone is going to make a difference there, or also patients maybe who are on higher doses of buprenorphine, which with Tennessee prescribing guidelines, they do a really good job of making you feel super nervous about doing that. Never mind, FDA is approved up to 32 milligrams a day. Anybody have any comments, questions, or patient cases they would like to share with us that reflect some of the things we've talked about today?
Joyce, I'd appreciate if you don't mind elaborating on what you just said about, that makes you feel super nervous. I'm not a prescriber myself. So I need to learn a little bit more about the nuances here. What is that pressure, or what are those hoops to jump through?
So we have this lovely document called the Buprenorphine Prescribing Guidelines. So I have to couch this in a little bit of context. I'm from Tennessee, grew up here, trained here for my medical school, went to North Carolina for residency, and then I went out to New Mexico and spent a little over 10 years in practice out there, and that's where I started doing addiction medicine. And in New Mexico, the restrictions, aka guidelines, that we experience here in Tennessee are not present in New Mexico. So when I moved back and started practicing addiction medicine, I felt very uneasy. The way I was used to practicing seemed to be questionable based on review of the guidelines. I followed the evidence that I had available to me. I knew the FDA requirements. When I first got here, I think 16, if you prescribed anybody over 16, you were looked at like you had two heads. Never, like one particular patient I had who during her pregnancy had titrated her up to 24 milligrams. Small thing, low BMI. She had a high metabolic rate. She was also pregnant and growing another human being, and she was having withdrawal symptoms. So I bumped her up to 24. And some of the pushback I experienced, including reaching out to area providers about, because she was pregnant, and I'm like, she needs OB care. I'm the one doing it right now, but I don't have privileges to deliver her at our hospital, so I need to involve somebody to know her who can deliver her. And as soon as I started talking about her case and I mentioned how much buprenorphine she was on, nothing else that I talked about mattered. Everything was like, well, she's on 24, you got to get her down. That's the first thing you need to do, blah, blah, blah. There's that suspicious. And I'm just like, you know what? I'm driving, which I wasn't. I'm about to go in a tunnel, which I wasn't. I think I'm going to lose you. Oh, I'm just hanging up, because that was not helpful at all. It was very judgmental, not hearing about the patient case at all, really stuck on what some numbers that had nothing to do with the individual in front of me who was needing the care that she needed. And my previous practice had been such that I was able to provide appropriate medical care based on the current evidence. And then it just felt very different when I first got to Tennessee. It took me a minute to understand kind of where they'd come from and how they'd arrived to the guidelines that they had, and appreciate the fact that that was something of a compromise between this isn't going to happen at all and something has to happen. And so that's where we landed with the guidelines. I've gotten more comfortable with them, but it still seems to be a lot of people get really stuck on things that have less to do with taking care of human beings and the evidence that's available to support the care that we provide. I've had people tell me things like at X milligrams, all the mu opioid receptors are saturated in the brain based on functional MRIs. I'm like, okay, UHC guy, can I get a functional MRI on my patient to see if all of my mu receptors are saturated or if I've got room because I need to go up on my dose? Is that something I can do? No, you don't want to pay for that? Okay, then I'm going to put them on the I need. So that's what I'm talking about.
Okay, no, I appreciate it. That's super helpful. And as you were speaking, I'm just going to be frank, and that it's kind of amazing. You know, they have these, I'll call them precautions in place, and other things from their standpoint. But on other parts of even just behavioral health care, I mean, what about? I mean, I would love for someone to look at antipsychotics and how much is being prescribed in certain ways, and some of these sedatives. And so this is one clear example of continued stigma and I mean, borderline discrimination as we're looking at access to healthcare, and we have a long way to go in advocacy.
Agree. Well, when I look at the guidelines for prescribing buprenorphine with the appendix and everything included, it's over 50 pages. And the guidelines for opioid prescribing, 3. I think it's 3. It's much shorter. And buprenorphine is a far safer agent. So there is some just really weird treatment of this medication in our state and other states. It's not unique to Tennessee, but having come out of a state where the practice approach and mindset is lenient, liberated, progressive, I don't know, pick a word, where it's just not so restrictive. It was a hard dive into a cold pool of water for me coming into Tennessee and trying to practice evidence-based medicine.
Is that 8-hour training requirement? Does it apply to prescribers who want to prescribe other types of opioids, or is it specific to buprenorphine prescribing?
No, it's only prescribed for the buprenorphine, and the other controlled substance, pretty much whatever you learn in the medical school or any training that you have would be appropriate for it. And I'm just, echoing what Joyce was saying. Buprenorphine and gabapentin are in the same class 3. And gabapentin doesn't have that much of the kind of paper to review in order how to prescribe it, how much you prescribe it. It's only, maximum dose recommended by FDA. And buprenorphine maximum dose is 32, which is recommended. And they research shows that above 32, most likely there are not too many receptors for most of the people to be, working for that above 32. But that is what the, pharmaceutical and the FDA put it down. But as Joey says, seems like that everyone looking at the morphine equivalent of the medication, and if this is the only medication that the morphine equivalent doesn't really count when they say 1 milligram of the buprenorphine is equal to the 30 milligram of the morphine, it doesn't really mean that it works that way. And this is also a FDA and a CDC report that this don't count the morphine equivalent. But when they go to the CSMD and they look at it, and all of a sudden they see that you have the patient on 8 milligram of the buprenorphine, and it calculated 240 morphine equivalent, and there is a red line there that is above 100 morphine equivalent. And that is a mistake that the DEA is doing, and that's a mistake that most of those providers that they are not familiar with this medication, they look at and they get scared. And as Joyce says, if you have someone on a 24 or 16, gynecologists, they go there and they get scared and they start thinking, okay, if we bring it down to the 2 or 3 milligram, then we are okay, and which is not going to work. So, and most of our patients that they were forced by the gynecologist to reduce the dose, they were getting extra dose from the street in order to survive until the baby was delivered.
Wow. No, I appreciate all that. I forgot the name of it off the top of my head, but you reminded me of this. It's like a red flag scoring system that I know that many pharmacies are using that creates a numerical risk score. And it does not, to my knowledge, unless something's changed recently, account for differences between buprenorphine and other types of opioids. So basically, I mean, I think if someone were to have been doctor shopping or pharmacy shopping and then they get into treatment, we might expect to see that. And that's not a concerning red flag for someone who's just started buprenorphine treatment. But unfortunately, based on our research that found that less than half of Tennessee pharmacies will fill a new patient's buprenorphine prescription, it seems very clear that these systems and also the pressure and fear of the DEA, distributor actions and internal limits are really interfering with the delivery of care.
Agreed. One of the things, it's a hoop we have to jump through. We have to do the PMP or the CSMD, whatever it's called in whatever state you're in. We have to check it for opioid prescribing guidelines. It's like once a quarter you're supposed to check it. Make certain they aren't getting a bunch of it other places. Every time we prescribe buprenorphine, we're supposed to check it. It's really such a waste of time, because what I'm concerned about my patients taking, the people they're getting it from don't put it in that system because they don't have access to that system, because they're not pharmacists or pharmacies. I'm more concerned about the fentanyl they're buying off the street, along with the methamphetamine and the crack and the other stuff that doesn't go into that system. So it's annoying to have to check it as much as we have to.
How long does it take? How long does it take for you to pull a patient on CSMD?
It's not that long, but it's one of those and I have to do one more thing. A whole other bunch of sets of clicks that I need to go through. And then you could delegate it to somebody else. But at the same time, a lot of times it feels like an unnecessary step, especially when you think about the respiratory suppressing, highly divertible, definitely related to a number of overdoses, only has to check the PMP every quarter. And I check it every time.
Yeah.
Oh, I gotcha.
Yeah, and same goes for the urine drug screen. I mean, if you have a patient on a regular opioid OxyContin, you check it twice a year, and that would be appropriate for them to make sure that they are taking their medication, and also they are not taking anything else that may cause the respiratory problem and things like that. And same thing goes with any controlled substance. But for the buprenorphine, you do it pretty much at least. I mean, if someone is stable, I think it's 8 of them in the state of Tennessee, at least 8 UDS per year. So, and that's a little bit relief that they get 4 times at least less, but it's not even close for the and the stigma it created by the providers of the service. The stigma was really placed by those legislative kind of the order, and unfortunately that regulation doesn't come from a very educated addictionologist. Is just a group of the people, they sit down and they talk about how to control the buprenorphine, but they don't sit down and do the same thing for the OxyContin. So
that I didn't know that. I'm assuming that is for TennCare and Department of Mental Health funded patients only. Would that be accurate?
It's for anybody.
for everyone.
Anybody getting
I'm not, I just want to say, like, I know for fact that people don't have that experience who do pay in cash. So I don't know if it's necessarily an insurance requirement or something else. I'll have to double check on that. So if someone has that rule, I would love to take a look at it. But that's a lot of lab fees.
Well, the regulation is for the prescriber. So if I lose my license if I don't follow the state law. So that's the part that we have to document, that we did the UDS, for example, for this patient, and in fact, when a few years ago, I needed to really report the UDS to the pharmacy too. So I would write the prescription and I have to write it down that UDS was performed and is appropriate on my note there, or tell the pharmacy that. And that was, for the buprenorphine only. I could write the 120 of the OxyContin for the patient because my DEA covers that, and the pharmacy would not even pick up the phone and call me. But for this one, would usually have to have that kind of the regulation. And I understand that they were concerned, but they made it too much for one medication that is safer than those medication that we're supposed to treat the patient for it, to come off of the regular stronger opioid. And it's been 20 years now, so 23 years from the time that the buprenorphine came on board. And when they work hard for 23 years to put the stigma on, we have to work another 50 years to take that stigma off of the buprenorphine. And by that time, most likely 20 other medication would come on board. So,
and Caleb posted the buprenorphine treatment guidelines PDF to our chat as well. Anybody who wants to grab that and read it, it's there, get it, enjoy it. It's a fun read. It's enlightening, just to sort of see what we are subjected to. And Caleb also put up, where did it go? What you had mentioned before, the full article from JAMA, that's a woman who works in our office. I always get it flipped. JAMA, Journal of American Medical Association. And then Elliot did put up about initiating buprenorphine in the ED. There's been a pilot project in the state of Tennessee. I know that like TennCare and others have been very interested in a pilot project for initiating buprenorphine in the ED, and related to, because for a while getting people in emergency rooms to engage in this type of care and the X waivers and can I prescribe it and what I do in the ED, and them coming back and treating this, kind of a clinic instead of an emergency department, that there's been, it's sometimes it can be a really tough sell for our colleagues in the ED, because you can imagine, I've got people waiting to get their next dose of buprenorphine because I'm treating this like a clinic, and I just had a major car accident and 3 people with massive heart attacks, and I'm supposed to be doing what right now? So there are a lot of different ways to go about initiating buprenorphine in the acute setting, like an ED or in hospitalized patients. And I'm glad that they're interested in wanting to do more with it, but also part of the development that needs to happen is, if we initiate it in the ED, where are they going next? Caleb mentioned the bridge programs. That's a name given to clinics. I think we all just use it generically, but it started in California, where through that acute initiation of buprenorphine at a hospital setting, and then having these bridge clinics that connect you from the acute care, continued care, and then care in your community. Sometimes individuals do stay in the bridge clinic long term. There's a bridge clinic at Vanderbilt, Vanderbilt University. They have one. They are associated with their addiction medicine fellowship, and I've gone to visit it. They usually keep people for about 3 months in their care. But if you're somebody who ended up in the Vanderbilt emergency room, got started, or inpatient service and got started on buprenorphine, and you live 2 hours outside of Nashville, you're connected to a clinic that's kind of a long drive back and forth. So they do work to connect you to providers in your community. And developing providers in those communities is important, which is why we are here for ECHO, so we can engage people across our state and other states and bringing up the level of education and understanding around treating substance use disorder. Some of the barriers we face, some of the commonalities that we all share, an opportunity to experience others' experiences, learn from them. And we want you guys to tell all your friends, family, everybody, come join us. It was put up by Melissa. Thank you. Our upcoming sessions. Dr. Hayel Cameron is going to be talking about substance use disorder and sleep issues in 2 weeks. Meredith and I will be going over traumatic brain injury and substance use disorder, those overlaps and challenges. It is definitely a not uncommon combination that we'll see when you think about substances and the trauma that can be associated with the use of different substances, and the sequela of a traumatic brain injury and how that impacts substance use disorder and their experience with it, and our experience treating them for their substance use disorder. At any rate, those are a couple of things we have coming up. So look at that list of upcoming lectures. Be thinking about people that you maybe have seen or heard about in clinics, or things you want to know about related to those topics. And we look forward to seeing everybody with friends and family. Bring them all, more the better, in 2 weeks from now. Thank you all for joining us today, and we will see you in 2 weeks. Thank you. Bye.
Joyce, as people are leaving, I just was going to say to you real quick that I think I'm going to take a look at the code, Tennessee code related to the guidelines. I'm thinking that there is not a legal statute to follow everything exactly. Of course, we need to understand how boards of health may interpret this and whether they require adherence, and that would be specific to each individual, could be specific to each individual board of health. But I do think, yes, these are cookie cutter doesn't work, period. The end for any kind of treatment. So if I understood these were meant as guidelines. I did not understand that they were meant as requirements. And I think we might want to get some clarification on that.
So some of the guidelines match up to some of the requirements from insurances. And then there's also the OBOT regulations.
Okay.
And then that's kind of where you get that cross section from guidelines to like CMS rules. And it's very murky and weird. And then like statutes. And when I have a patient, previously I haven't had to do this in a while because TennCare has made some changes and pushing it forward through legislation so that, you know, for someone who is an addictionologist, I can write up to 24 milligrams. Granted, on my PA, I have to say that they have history or current, I can't remember which one it is, IV use to get that higher dose. Never mind, we're still below the threshold of what it is for the FDA that says I can prescribe up to 32 milligrams if needed. So some of things have gotten better as far as our ability to provide what we feel is appropriate for the patient in front of us. But I have in the past, and this has blew my mind, when we were denied a PA and go through the appeals process, instead of getting to do a peer-to-peer conversation where I'm talking to another physician for my clinical reasoning behind requesting when I'm asking for my patient, I end up talking to a lawyer who tells us we're going to get to talk to a judge.
What?
Yes.
that doesn't make any sense.
Because that's the statute, and it has to be reviewed by legal as to whether the way that the the prescribing rules are written that my patient would be allowed an exception to that rule. And so it's a judge that's making that determination. If they deem
I would
that an
love-
NP or a DO.
If you can help, no rush, just at your convenience, or someone can, I think we need to take a look at that. I would like to actually dive in and see where that requirement comes from, the language, and figure out what we can do about it. I think we do have some barriers to advancing legislation regarding buprenorphine in the state General Assembly, given some key leaders. But I do think some things like this, we might be able to work on through some rule changes and otherwise, but I'd like to look at it and see how we can help.
Okay.
All right, thank you.
All right, thanks, Elliot. It's nice to hear you again.
Yeah, same. Bye-bye.
Bye.